All right. So welcome everybody. We are the topic of this lunch and learn is one that we actually haven't done in a long time. So I'm excited to revisit the always important topic of toxic stress, childhood trauma, adverse childhood experiences. So what we're going to do is we're going to watch the Nadine Burke Harris TED Talk video, which I think that everyone probably has already seen that. If not, it's wonderful. I've watched it many times and I enjoy it every time. And then we're going to probably take a little break and talk about that, and then go through an ACEs training, which is actually out of England. But I think it's a wonderful training. It's very basic, but it's also very relevant. One of the things about the ACEs trainings that I've noticed in the US, especially the ones that are online and free, is that they're typically geared towards healthcare providers, so doctors, nurses, and like professionals, quote unquote. And they're I don't know, they're relevant, but not really for our purposes so much. So let me do a screen share. And come on to remove my little thing here. There we go. Okay. Everybody can see that? Yes, you can see my screen?
Yes.
Okay. All right, so we'll go ahead and get started with the TED Talk then. Does anybody have any questions before we dive in? No? Okay.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States.
Something happened to the audio.
Yeah, I think, Robert, if you're on mute, we can't hear. Maybe?
Oh, I apologize. Okay, let's see. Hold on.
Yeah, not you, that everybody have problem.
And yet doctors today are not
Can you hear it now?
Yes.
Okay.
trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a pathogen chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California. And together, we opened a clinic in Bayview Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities, access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. a lot of kids were being referred to me for ADHD or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Anda at the CDC. And together, they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you know, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand better than we ever have before how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal system, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you'll want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. from tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across the lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real and this is all of us. I believe that we are the movement. Thank you.
So let me stop sharing for a second. Okay, there we go. I assume that there are many of us who've already seen that. Have seen that that TED Talk, and it was what 6 years ago that I think that she did that. Since then, she has become California's first Surgeon General. She wrote a book called The Deepest Well, which I think was a national bestseller. You know, and her approach certainly is from a medical perspective, right? Because she's a pediatrician, so she's going to certainly be employing the medical model. But I think that the awareness that has been raised about ACEs, especially by her, really has been instrumental in, for example, the state of California now will reimburse providers for providing an ACEs screening. So there's the actual ACEs screening tool that the ACEs Foundation, I guess I'm not really exactly sure the name, but they provide training on it, and they have a screening tool, and Medi-Cal will reimburse for those screenings so that the ACEs can be identified and mitigated. Hopefully, that's the goal. Does anybody have any comments, questions, concerns, critiques, or anything of anything that was discussed in the video or just ACEs in general?
I have a statement.
Sure.
The one thing about her speech that hit me the hardest is that we don't want to face this because it's endemic in all of us. You know, that most of us, and it probably comes down to that complaint by a lot of people about children getting trophies for participating rather than winning. You know, that if all of us have to face trauma, some of it light, some of it, you know, pretty invasive. But I mean, I don't understand how something that pretty much incorporates all of humanity can be a treatable disease.
Mhm.
Just a thought.
Yeah, absolutely. And I think we're going to talk about that in the other part of the training, the actual training that we're going to go through here. But yeah, I mean, I think that you're speaking to the fact that it's the ACEs are pervasive. I mean, really within society and with culture, within our culture. And I think that just the fact that we're raising awareness of the certainly the health implications of ACEs, as well as, you know, the physical health and mental health implications of ACEs. You know, this movement, research, whatever you want to say, really is still in its infancy in terms of how long it's been around. So I think that as things progress, I think we'll really start to see some things come to fruition in terms of treatment. But I think at this point, really, it's more of an awareness. It's more of an awareness component of that. But I appreciate that. I think that that's certainly an important consideration, Brendan. Anybody else on here? No? Okay, well, I'm going to go ahead then and resume sharing down here. And what we're going to do, if I can find my camera is like in the worst possible spot. It like hides all my stuff. It hides all my things. There we go. Okay, so we're going to go ahead and go through this together. Let's see.
Welcome to the Introduction to Adverse Childhood Experiences and Early Trauma online training.
So what I'm going to do, I'm actually going to skip ahead because this first part is just an overview. So I'm actually going to skip ahead to this, I think.
Child development and toxic stress. Let's take a look in more detail at different types of stress. It's important to distinguish among three kinds of responses to stress: positive, tolerable, and toxic. These three terms refer to the stress response system's effects on the body, not to the stressful event or experience itself. Select each of the circles for more information on each of the different types of stress. Positive stress response is a normal and essential part of healthy development, characterized by brief increases in heart rate and mild elevations in hormone levels. Some situations that might trigger a positive stress response are the first day with a new caregiver or receiving an injected immunization. Tolerable stress response activates the body's alert system to a greater degree as a result of more severe, longer-lasting difficulties, such as the loss of a loved one, a natural disaster, or a frightening injury. If the activation is time-limited and buffered by relationships with adults who help the child adapt, the brain and other organs recover from what might otherwise be damaging effects. Toxic stress response can occur when a child experiences strong, frequent, and/or prolonged adversity, such as physical or emotional abuse, chronic neglect, caregiver substance abuse or mental illness, exposure to violence, and/or the accumulated burdens of family economic hardship without adequate adult support. This kind of prolonged activation of the stress response systems can disrupt the development of brain architecture and other organ systems and increase the risk for stress-related disease and cognitive impairment well into the adult years.
Let me go back.
Tolerable stress response.
Pause that. I think that we're going to see this repeated again in future sections, but I think one of the very important takeaways from what we're going to talk about is the differences between positive, tolerable, and toxic. And the differences between specifically tolerable and toxic are the fact that it's time limited and buffered by positive relationships with adults, essentially. And one of the things that struck me in terms of relationships with adults is specifically the relationships between our CASA kids and their CASAs, which is certainly one of the points of the CASA program, is developing the safe, stable, reliable adult relationships with youth who are in foster care, who have typically not had a lot of those types of relationships in the past. So that was one of the things that really stuck out to me on this section.
Typically, when faced with some kind of threat or stressful situation, your system goes to a higher level and you go into a fight or flight mode. This might include responses such as running away, fighting, or freezing. Then you come back down again, rest, relax, and your body recovers. This is tolerable and can be positive. When exposed to chronic stresses or adverse childhood experiences, your body doesn't come back. For evolutionary reasons, it sets itself to a higher state of alert permanently. This is what we might refer to as toxic. That permanent higher state of alert has a lot of consequences. If you set any system to a higher state of alert, it wears out quicker. And that's fundamentally what's happening. Experiencing adversity during childhood impacts our bodily functions, such as heart rate, digestion, respiratory rate, and pupillary response. These experiences can alter our neural circuits, which distinguish whether situations or people are safe, dangerous, or life-threatening. This means that these children and young people spend a significant amount of time in a state of what's known as hyperarousal, facing significant emotional distress, which adversely changes a young person's ability to regulate their emotions. Let's take a look at two possible outcomes that might occur depending on how the brain is developed during the early years. Let's suppose that all babies have a neutral start in life. Then imagine that one baby starts their early life in a safe and supportive environment, whilst another baby starts their life by being neglected and not cared for. Let's now take a look at the possible outcomes for each of these babies later in life. The first baby, who is cared for and felt safe, is preparing themselves for life in a giving and compassionate world. This child will typically become an individual who is laid back, relationship orientated, and thinks things through. The outcome will be that they have adapted and learned to live peacefully in good times. The second baby, who was not cared for and neglected, in contrast, is now preparing themselves for a tough life in what they believe is an evil world. This child is likely to become edgy, hot-tempered, impulsive, and will be hyper-vigilant. The outcome will be that they have adapted and learned to live in a survival mode in the worst conditions. So it is clear to see that giving babies a good start in a safe, supportive, and cared-for environment is important for later development and adult life. It is also very important to remember that interventions could also change a person's life path onto a better course.
And I think that that's one of the things that underscores the fact that some of the kids that we work with have some pretty significant behavioral issues, and really do suffer from this, exactly what we're talking about here. We're going to talk about coming up here about risk factors and things, and I know for a fact that many of you who are on this training right now have youth who will have experienced every single one of the things that we're going to talk about. So that really does impact brain development, behavioral considerations, and those kinds of things.
Why is attachment important? Select your answer below and then check your response. A secure attachment formed within a safe and stable relationship with any caregiver provides children with a secure base to take appropriate risks and supports healthy brain development. B, it makes children feel important, which helps them develop a positive sense of self. Or C, in order to experience healthy brain development, a child needs a good relationship with their parent.
This answer is this.
Yes, that's right. Well done.
Oh, thank you.
Okay, time for another knowledge check question. With regards to toxic stress, which of the following statements do you think is the most accurate? Select your answer below and then check your response. Yes, that's the correct response.
Oh, look at me.
Well done.
2 for 2.
The impact of childhood adversity. By the end of this section, you will understand that experiencing adversity in childhood can have a significant effect over a person's life course, resulting in ill health, poor well-being, and in some cases, premature death.
Before we go on to section 3, does anybody have any comments? Anything they want to bring up over what we just went over? No. Okay.
The impact of childhood adversity. A major US study uncovered a strong relationship between ACEs and risk factors for ill health and poor well-being. Research in England, Wales, and Scotland replicated these findings and suggest that ACEs are strongly associated with adverse behavioural, health, and social outcomes in childhood, adolescence, adulthood, and later life. All these studies were based on an evidence-based conceptual framework for thinking about the impact of ACEs on a child over the course of their life. This model demonstrates that there is a progression of outcomes.
One of the things I wanted to mention from what was just discussed, but went dissolved away, I thought it was interesting that the focus of the research done in the US was really specifically looking at physical health outcomes, whereas the research that was done in the UK had more focus on behavioral and mental health effects. I thought that was very interesting. But we can see here, so at conception, it goes conception to death in this reverse upside down triangle. That experiencing adversity and trauma certainly leads to physical health issues, but also, like, for example, challenging behaviors, risky behaviors, those kinds of things.
Research has clearly shown that experiencing adversity in childhood can have a substantive impact across the life course. These experiences increase the risk of poorer physical and mental health outcomes in adulthood. ACEs also result in higher rates of avoidable death from natural causes, including from the leading causes of early adult deaths, such as heart disease, respiratory disease, and cancer. Women who had experienced one adversity had a 66% increased risk of premature death, and those who had experienced 2 or more adversities had an 80% increased risk compared to their peers. In contrast, men who had faced 2 or more adversities in childhood have a 57% increased risk of early death compared to their peers. The impact of childhood adversity over a life course. Select each number along the journey for more information. A child who experiences a significant ACE might also experience the next steps over their life course. Disrupted brain development. Signs of social, emotional, cognitive problems. Remember, appropriate intervention and support could help improve a young person's life experiences. Risky or challenging behaviours and/or relationships. Physical, mental ill health. Early death. Public Health Network Cymru has created this short animated film to raise awareness of ACEs, their potential to damage health across the life course, and the roles that different agencies can play in preventing ACEs and supporting those affected by them.
hoping this is going to work with the screen sharing thing. I don't think it's going to. I'll just skip.
Social
Sorry.
health and community impacts of ACEs early trauma. By the end of this section, you will be able to identify a range of social and community impacts resulting from ACEs. Social health and community impacts of adverse childhood experiences early trauma. For every 100 adults in England, 48 suffered at least one adverse childhood experience. 9 suffered 4 or more. 52% suffered no ACEs, 23% suffered 1 ACE, 16% suffered 2 to 3 ACEs, 9% suffered 4 or more ACEs. How does it impact the lives of young people? Adverse childhood experiences impact a child's development, their relationships with others, and increase the risk of engaging in health-harming behaviours and experiencing poorer mental and physical health outcomes in adulthood. Compared with people with no adverse childhood experiences, those with 4 or more adverse childhood experiences are 2 times more likely to binge drink and have a poor diet, 3 times more likely to be a current smoker, 4 times more likely to have low levels of mental well-being and life satisfaction, 5 times more likely to have had underage sex, 6 times more likely to have an unplanned teenage pregnancy, 7 times more likely to have been involved in violence, 11 times more likely to have used illicit drugs, 11 times more likely to have been incarcerated. In addition, those with 4 or more ACEs are more than twice as likely to have visited the GP regularly and to have visited A&E. Their premature mortality is estimated to be more than 1.5 times more likely.
So these statistics are applicable to the UK, which is where they're pulling their data from, but it's very similar in the US. Children who have been involved in the foster care system, especially youth who age out of foster care, have terrible outcomes and will experience many of these things. And rates of homelessness for youth who age out of foster care are staggering, honestly.
This diagram shows the percentage of individuals diagnosed with a major disease by their age. As you can see, only 46% of those with no ACEs were diagnosed, compared with 78% of those with 4 or more ACEs. Preventing ACEs in future generations could reduce levels of poor diet by 14%, binge drinking by 15%, smoking by 16%, early sex before age 16 by 33%, cannabis use over a lifetime by 33%, unintended teen pregnancy by 38%, violence victimization in the last year by 51%, violence perpetration in the last year by 52%, incarceration over a lifetime by 53%, heroin or crack use over a lifetime by 59%. So what can we do? Spread the word. Help towards getting ACE-informed professionals, politicians, and the general public. Identify ACEs. Help promote protective factors and increase resilience. Address the root causes, not the symptoms.
And this goes really back to Brendan's question, I think, that he raised. What can we do? And the main one is spreading the word and raising awareness. Getting people the help that they need once the ACEs have been identified. How do we mitigate that? So mental health services, other supportive services can be very impactful. Before we go on to section 5, does anybody have anything to say?
I thought it was really interesting that the way they categorized, the 5%, 10%, 15%, they started out at the low end, which I would call, just moderate overindulgence, not life-changing impact. And that so it reduces that by 5% or 10, some low number. And then you start looking at Well, it reduces your propensity to violence by 40% and drug use by 50%. That what we consider the more severe social issues, that's where the impact is the most, which kind of does go to the point of yeah, if we could get a hold of this, if we could manage this and figure out how to treat it, then yeah, we would be solving the problem at the root. You talked about kids aging out of the system and how terrible it is, what the when they age out of the system, that it doesn't have good outcomes. And as you were saying that, I was thinking, so okay, so we put in a bigger safety net to catch those people as they come out of the system, and that's putting on the band-aid after the accident.
Yeah.
If we could do something earlier on, and so we talk about doing something earlier on, and you say, yeah, again, it's social services and making sure they're cared for. But from a scientific perspective, if you actually address this from the point of view of ACEs, you actually do look, you're approaching a cause and effect that will reduce the overall impact. So that was kind of interesting.
Yeah, I completely agree. And one thing that I would add is that in terms of risk factors and mitigating things that we look at as being a pretty significant social issue is rates of homelessness. And the one thing that they really haven't talked about are rates of homelessness because they really don't have the kind of homelessness issue in the UK as we have here, because they have a lot more services that they provide their population. So rates of homelessness for former foster youth who've aged out, runaway foster youth who are currently in the system but have run away, are huge. And that follows along with rates of homelessness in the US. So it really, and then of course you run the risk of sexual exploitation, CSEC, and all things that go along with drug use and unsafe conditions that go along with that. But yeah, there's a lot to it. Thank you, Patricia. Heather, did you had your hand up?
I did. Along the lines of seeing symptoms and getting to the root of the cause, what keeps popping into my head is also advocating for help for the parents.
Yes.
Oops, sorry, the dogs are getting loud. I don't know if you can hear me.
You're fine, you're good.
Hey. Okay. Advocating for the parents, understanding if a parent is talking to you or anybody, getting resources out there about meetings and their own, mental health and things. I mean, when the parents are going through the cases and they usually are given a plan for some rehabilitation, but I think as a CASA, it's important to reduce the stigma of like substance use disorder, understanding it in our parents so that we're more compassionate and understanding with them and not judgmental or blaming. It makes for a better, heart system for everyone. And yeah, just like helping to fight the stigma of that, having the willingness and compassion, and just being aware of resources that are out there if someone does ask, because sometimes people will be like, hey, this person's having a hard time drinking, but they're not going to say anything. And knowing, hey, go to aa.org or, whatever, gamblers, what there are so many resources. And even in our county, here we have a lot of resources too. So that's what was popping up for me, because if we can help the parents and start breaking the cycle of where this destructive behavior is coming from, then we'll have a lot less ACEs.
Absolutely. Thank you, Heather. That's a really good point. And that's something that Sarah and I talk often about is, if so much, if some of the, even some of the money that's thrown at other causes could be given, given to the parents for additional supports, additional services, those kinds of things. We could see, I think, a huge improvement. And CASA volunteers, are traditionally working only with the youth, but that doesn't mean that all of them do, and all of them are exclusively working with youth. We have a lot of CASAs that do support the parents, and then maybe kind of with outside of the scope of the training, especially that CASA volunteers go through before they become a volunteer. But that parental support is hugely important. For example, Maria, who is on the training right now, her CASA kid is an infant, and so she's working a lot with mom, and so that support, I think, is really important, even if it's just being a sounding board. I think that sometimes mom calls just to vent, and that listening ear that Maria provides, probably for mom especially, is invaluable. So it's very important. Does anybody have, not to put Maria on the spot, but does anybody have anything that they'd like to add to or share with that conversation?
I really hope what you say is true. Also, one beautiful thing that comes to my mind is just the fact that the brain is so plastic, and our genetics can, things can be turned on and turned off, and so it's a terrible situation, and there's a lot of hope too.
Yeah. Yes. Thank you. Absolutely. That external factors can help mitigate the impact of toxic stress. And I would add that Maria is a psychologist, and so she certainly has some very valid points with that. So thank you very much. I'm going to go ahead and go on to 5, unless anybody has anything else. All right.
How do adverse childhood experiences impact across a life course? Select your answer below and then check your response. A. Those with 4 or more ACEs will experience significant negative outcomes across their life. B. People who have experienced ACEs are at increased risk of potential negative impacts across their life course. Or C. Adverse childhood experiences only affect children.
What do you think, B?
Yes, that's right.
look at that.
Well done.
Oh, thank you.
Protective factors. By the end of this section, you will be able to give key examples of protective factors that can help prevent ACEs and different strategies that can help build resilience. Let's now take a look at key risk and protective factors that can impact negatively or positively on children and young people's mental health. Select each area to find out more about the risk and protective factors for each one. Some risk factors for children include genetic influences, having a low IQ and learning disabilities, specific development delays, communication difficulties, the child having a difficult temperament, physical illness, academic failure, and low self-esteem. Key protective factors that can have a positive influence on a child include those around them having a positive attitude, having experiences where success and achievement is felt, having the capacity to reflect, feeling a secure attachment experience, developing good communication skills, and having belief in control. Risk factors within the family can include family disharmony or breakups, primary carers or parents having an inconsistent discipline style, having a parent or parents with mental illness or substance abuse, physical, sexual, neglect or emotional abuse, parental criminality or alcoholism, and experiencing death and loss within the family. Key protective factors that will have a positive influence on a child within the family setting include family harmony and stability, supportive parenting, having strong family values, affection, parents delivering clear, consistent discipline when needed, and having a strong support for education. Risk factors within a school environment can include bullying, discrimination, a child having a lack of positive friendships, deviant or negative peer influences, peer pressure, and poor pupil-to-teacher relationships. Key protective factors that can foster and create a positive environment whilst a child is at school include having a positive school climate that enhances belonging and connectedness, having clear policies on behaviour and bullying and an open door policy for children to raise problems, and a whole school approach to promoting good mental health. Potential risk factors in the community include socio-economic disadvantage, homelessness, disaster, accidents, war or other overwhelming events, discrimination, having a lack of access to support services and other significant life events. Key protective factors in the community can include building wider supportive networks, providing good housing, having a high standard of living, providing opportunities for valued social roles, and a range of sport or leisure activities that bring people together in a positive way.
And I would add that protective factors in any of these categories can be provided even by one person. So even if you have, you could, the child, the family can have a whole host of risk factors, but a key protective factor can be just one individual taking an active, positive role in the life of the child or the parent. I went to a training one time, and the trainer spoke extensively on that, the fact that one positive adult relationship with a child or an adult who's struggling in a family can have a huge positive impact.
What are protective factors? A definition of risk or protective factors from the World Health Organization states that risk factors are conditions or variables associated with a lower likelihood of positive outcomes and a higher likelihood of negative or socially undesirable outcomes. Protective factors have the reverse effect. They enhance the likelihood of positive outcomes and lessen the likelihood of negative consequences from exposure to risk.
And a CASA can be a protective factor, certainly.
Protective factors are like a shield to protect children from ACEs and build resilience. They are things like loving, supportive, resilient parents who read and talk to their children, who spend time with their child and let them know he or she is loved and has a purpose in life. Having healthy, supportive and stable relationships with relatives, family members and friends. Providing parents concrete support in times of need and facilitating knowledge of parenting and child development. Enabling their child to make good choices and having as many healthy, positive experiences as possible. Using serve and return activities with children, such as reading, rhymes, singing and talking. Learning good communication skills and recognizing and understanding the feelings of others and having safe, supportive and positive learning environments. Parents or caregivers always being there for their child when they need support and encouragement, and shielding their child from toxic stress by working to prevent negative experiences. If there are no protective factors for a child, toxic stress can affect brain development. The most important protective factor is a caring, loving relationship with parents or caregivers. Families thrive when protective factors are robust in their lives and communities. By providing parents, childcare professionals, and others who work with children more information about these protective factors, we can help build protective factors in families with young children, building on family strengths and promoting optimal child and youth development. Ways to deal with stress. Here are some ways parents or caregivers can help their child deal with stressful or potentially stressful situations. Teach children how to deal with and respond to aggressive behaviour and how not to be a victim. Get warning signs of bullying and learn how to take action. Set rules and limits. Children want and need you to teach them what is allowed. Listen to your child's needs and fears. You may need to adjust daily activities to help them through a rough period. And provide emotional coaching and validate emotions by helping children understand that all feelings are perfectly normal. Parents taking good care of themselves. Children learn from their parents' behaviour. If parents handle times of stress by being positive and confident, their child will notice and learn from it. It's one of the most important ways to build resilience in children. Here are the things parents can do to take care of themselves and show their child how to cope with stress. Tap into support systems. Connect with mental health and/or substance abuse treatment when needed. Eat healthy foods. Get enough sleep and physical activity. Stay positive. It will help your mental outlook and physical well-being.
And we're talking about protective factors. For example, they're talking right there about what things that parents can do. Those are things that parents can, if they're not, the parents can be encouraged to do, be supported in doing. Heather mentioned, for example, seeking treatment, those kinds of things. And also in making healthy lifestyle choices. A lot of our parents, in dependency cases, don't necessarily have a support system, don't have a family, don't have a healthy support system from friends. So just trying to provide that, I think, can be very, very important. And even it doesn't have to be anything huge. I mean, just phone calls, those kinds of things.
What are examples of good protective factors? Select your answer below and then check your response. A support, that's correct. Well done. Looking at ACEs through a trauma-informed lens. By the end of this section, you will understand what it's like to look at adverse childhood experiences through a trauma-informed lens.
So before we start section 6, does anybody have anything to add on 5? I think this is the last. Oh, it's not. Okay. Oops. Okay.
Trauma-informed care, TIC, assumes that an individual is more likely than not to have a history of trauma. Without interventions and supportive protective factors in place, the cycle of ACEs is much more likely to repeat from generation to generation. When you look through a trauma-informed lens, you recognise the presence of trauma symptoms and acknowledge the role that trauma may play in an individual's life. This means considering the potential widespread impact of trauma and understanding potential paths for recovery by recognising signs and symptoms of trauma in clients, families, staff, and people you may be working with. Then responding by fully integrating knowledge about trauma into policies, procedures, and practices, and seek to actively resist re-traumatisation. So someone looking through a trauma-informed lens might ask if a past experience might be the reason for a person's behaviour. So rather than asking, what's wrong with you, they shift to asking, what happened to you that led to you behaving like this? It is important to understand the magnitude by which people can have been impacted by trauma, and then to understand how our interactions with them can either be supportive and help them be more successful, or just the opposite. Out of ignorance, we can interact with them in ways that make them less comfortable. If you're providing a service, you need to anticipate that that person might be a trauma survivor. Mary. Example case study. After being physically and sexually abused from infancy into her teenage years, Mary doesn't want a doctor to touch her unless it's absolutely necessary. So going to appointments, where male nurses or physical exams are often emotional triggers, can be difficult. Mary has anorexia. She has submitted letters to her specialists requesting, among other accommodations, that she not be weighed because it causes extreme anxiety. Still, on a recent visit, a nurse asked her to step on the scale. A trauma-informed response in Mary's case might be medical providers saying when and why they need to touch her, looking out for signs she's frightened, like clenched fists, and saying her name frequently. Examples of how someone could adjust their practice include giving Mary a choice over which professional she sees and ensuring that this professional stays consistent so that Mary is able to build a relationship in which she is able to learn to trust the doctor, and agreeing how Mary would like to indicate when things are getting too much and would like to take a break. The 5 principles of adversity and trauma-informed models of commissioning and care should be based upon safety, trust, collaboration, choice, and empowerment. Select each circle for more information on what commissioning and care should provide early interventions to prevent an escalation of need and avoid preventable exposure to additional adversity and trauma in children and young people's lives. Policies, practices and safeguarding arrangements that avoid re-traumatizing the young people and stigmatizing their behavioral or emotional response to trauma. Safeguarding procedures, which are seen as part of interventions in childhood adversity and work in a way that supports the child or young person to recover from the adversity or trauma they have faced. And coordinated support from knowledgeable, qualified, trustworthy and well-trained professionals who have suitable supervision and workforce support that can address vicarious or secondary trauma that may occur. A trauma-informed professional or organisation will realise the widespread impact of trauma, recognise the signs and symptoms, respond, and actively seeks to resist re-traumatization.
And one of the things I would toss in there is that part of the advocacy that CASA volunteers often provide is helping to educate in other individuals who interact with the child in regards to the way that the children are acting. I know that, like, for example, in Patricia's case, there was some pretty significant acting out behaviors. There was a reason for that. So Patricia was able to help provide some education, I would say, to the caregivers, and that is a big part of CASA volunteering. Sometimes even with teachers, sometimes teachers can take a very punitive approach, and sometimes it takes another caring adult to say, hey, maybe the reason that little Susie's acting this way is because of XYZ. Maybe we could take a different approach in our interactions with her. So
Commissioning and care should ensure strong, positive, trusting relationships between trauma survivors, and that the people working with them follow through on what they have said they will do. They should also work with people accessing a service so informed consent is received and service users understand what will happen, who will do it, when, why, where, and what costs may be and what the aims are. Ensure that the language used by practitioners creates feelings of trust and belonging and works towards healing trauma. For example, calling it a home and not a placement for a child in care, not always speaking in terms of outcomes, and avoiding labelling people as perpetrators or offenders. In addition, practitioners should avoid using terms that they wouldn't use with their own child or families, and not using terms or language that may create feeling that people don't have the ability to rehabilitate or choose a different life path. Commissioning and care should work collaboratively with young people and provide models of care that enable alternative and more flexible forms of access and engagement. Adopt a strengths-based approach, recognising the resources and resilience that children and young people have drawn upon in the past, and creating positive and additional strategies, including self-soothing, emotional and regulation, and the promotion of self-care. Ensure models of care recognise and harness, where possible, families, caregiving, peer and community assets as part of treatment and recovery. Enable effective communication and data sharing between agencies to ensure that the whole of the child's needs are identified and met. And ensure that there is a continuity of care and consistency of pathways across and within the services and interventions that children and young people will receive.
So the collaboration component for us would certainly include CFT meetings and KDA meetings. That collaboration is very, very important across systems of care, because it can not only expose shortcomings in the care that the youth is receiving, but it's a time where a CASA could provide some feedback on ways of improving things, or suggestions, or just additional insight.
Commissioning and care should recognise that trauma survivors are likely to feel that they have limited control over the course of their lives due to their past experiences, and ensure that service users are given maximum choice over how their service will be carried out and experienced. and reinforce feelings of trust and safety by helping service users to feel like they have ownership over their experience and encourage what it is like to have a positive, healthy relationship. Commissioning and care should encourage practitioners to recognise the principle that trauma survivors often feel powerless to control what happens to them, and understand that they may feel isolated by their experiences and have very low feelings of self-worth. And help practitioners to give service users opportunities to take power for themselves, to take control and to take the lead in order to improve their feelings of self-worth and help to make them more resilient to their experience of trauma and adversity. What are the key principles of trauma-informed practice? Select your answer below and then check your response. A. Resilience, supportive relationships, safety and trust. B. Organisations promote trust, choice, collaboration, empowerment and resilience. Or C. Organisations promote trust, choice, collaboration, empowerment and safety whilst assuming that everyone has experienced trauma and will therefore benefit from the approach.
I think it's this one.
Yes, that's right. Well done. Building resilience. By the end of this section, you will understand how building resilience can help to mitigate the impact of ACEs.
Before we go on to section 7, does anybody have anything to add to 6? No? All right.
Resilience is important for emotional well-being. Select each segment for ways resilience can be built. Intelligence and problem-solving skills. Self-regulation skills. Perceived efficacy and control. Achievement motivation. Faith, hope, spirituality. Beliefs that life has meaning. Positive relationships with caring adults. Positive friends or romantic partners. Effective teachers and schools. Effective caregiving and parenting. Building resilience. The key building blocks of resilience are a secure base where the child feels a sense of belonging and security, being involved with others and feeling connected, good self-esteem, that is, an internal sense of worth and competence, being equipped to manage your behaviours and emotions, thinking positively and feeling that you can overcome hardships and guide your own destiny, having one or more stable, caring and safe adult-child relationships, and finally, a sense of self-efficacy or a sense of mastery and control, along with an accurate understanding of personal strengths and limitations. This is important as it acknowledges that children are not just done to, but are also agents in their own rights. This resilience framework theory attempts to explain why some children appear to do better than others, despite growing up in similar circumstances. It also provides a framework for assessing risk and focusing intervention on areas that will help the child or young person. Resilience and vulnerability refer to intrinsic characteristics of the child or young person. These may vary with age, and some caution is required. Examples of resilience factors include the child has someone who loves them unconditionally, has a sense of humour, likes him or herself. Adversity and protective environment refer to external, extrinsic factors. These are located in the family and wider environment domains. Ecological levels. Examples include factors such as race or culture, quality of community, economic situation. The framework of resilience considers 6 domains of resilience. The 6 domains of resilience are secure base, social competencies, positive values, talents and interests, friendships, education. In this section, you will find a list of vulnerability and resilience factors that affect children. Select each tab to have a look at the lists. Age, which includes early childhood trauma, disability, physical and learning, communication difficulties, poor attachment may be associated with developmental trauma, non-organic faltering growth, unwanted child, school non-attendance, self-harming. secure early relationships, being female, positive attitude, problem-solving approach, good communication skills, capacity to reflect, autonomy and self-motivation, good looks, pleasant personality, sociability, good sense of humour, intelligent ability to reflect and problem-solving skills, good self-esteem, easy temperament, positive leisure activities, hobbies or interests, talents, age, religious faith, opportunity to rehearse tasks, make decisions and take on responsibility, development of self-reflexivity, social understanding and skills, positive relationships with adults and peers, warm, supportive, secure relationships, acceptance by a responsible adult the child respects, accomplishing tasks valued by the child, basic needs met, including health needs, positive childhood experiences, recognition and praise.
I think it's interesting that the second point of resiliency and protective factors being female, and it's actually interesting because recent research has shown that females are inherently more resilient than males are in terms of overcoming adversity. I don't know that any research has been done to explore why. I just know that being female is inherently a factor of resilience. So I think it's very interesting.
Now let's take a look at a list of vulnerability and resilience factors that affect parents and carers. Just select each tab to have a look at the lists affecting parents. History of abuse or neglect, unrealistic expectations of the child, lack of insight into the child's needs, limited capacity to change, limited motivation to change, failure to prioritize child's needs, low warmth, high criticism, engaging in and condoning criminal behavior, lack of or poor knowledge of childcare and development, poor childcaring skills, child is scapegoated, child takes an inappropriate adult role, failure to protect from strangers, overprotection, school non-attendance, inattention to health needs, separation from parent or carer, poor marital relationship, learning disabilities, refusal to acknowledge concerns, refusal to engage with support, intimidating behaviour, previous children on child protection register, previous children removed, limited parenting strategies, limited coping skills.
And I would add to this that just because children are removed from their parents and placed in foster care doesn't make all of these go away, right? Because I know that we, many of us have seen children in foster care experience many of these items on this list in foster care. That's something certainly for the CASA volunteer to be on the lookout for. I think foster parents a lot of times have best of intentions, but don't always execute their intentions in the most positive way.
Consistent encouragement and support, stability and security, positive expectations, small family size, child-centered family, engagement with social services, acknowledgement of concerns, family previously coped for long periods, protective adult, presence of another safe non-abusing parent, positive relationship with child, adult has positive childhood experiences, motivation and capacity for change, willing to try new ways of coping, acknowledges risks posed by abusive partner and the consequences of failing to protect, supportive partner relationship, agreement reparenting style, acceptance of disability, parental interest and involvement in education, sets clear and consistent guidance and boundaries, absence of severe discord. And finally, take a look at some of the vulnerability and resilience factors that can affect the wider family and environment. Again, selecting each tab to have a look at the two lists. Economic social class, minority status, especially asylum seeking status, social isolation, multiple carers, instability, family breakdown, separation, loss, bereavement, poor home conditions, poor housing, homelessness. Positive school experience, one caring, respectful relationship, support, general and specialised, removal from risk environment, access to facilities, supportive relationships outside the home, positive peer group, adequate housing, lack of income worries, active involvement in school and community life, high morale school with positive policies for behaviour, attitudes and anti-bullying, access to a range of positive sport and leisure activities.
Is this one not going? Huh.
Questions to consider asking when assessing a child's vulnerability and resilience. Select each child on the left-hand side for ideas on what kinds of questions you can ask yourself to assess their vulnerability and resilience. What are the things that are going well in Abel's life? To whom is Abel important? Who is important to Abel? Who are the people who play a positive part in Abel's life? At home, in the community, school, or further afield? And in which fields can Abel find a sense of achievement? Has the school's special knowledge of asthma been considered in assessing her developmental progress, vulnerability and strengths? Does the primary caregiver have role identities beyond that of caregiver? Does the caregiver have a record of using help well or of ambivalence or defensiveness in the face of help? And has the caregiver had a chance to articulate his or her worries and views as part of the negotiation or formulation of a plan to address any childhood protection and welfare concerns? Does Olivia relate fairly easily to peers of her own age? Do there appear to be problems of bullying or being bullied? Does Olivia have hobbies and interests which are encouraged and supported? How does Olivia get on in school, socially as well as academically? And has the school been briefed adequately on Olivia's home situation? Is there a concerned adult outside the home who Kyle likes and trusts? Has Kyle got a realistic way of contacting this adult when necessary? As Kyle is a bit older, has anyone discussed a fallback safety plan, as he may occasionally be at risk of harm due to episodes of parental substance misuse or domestic violence? And do these adults have the confidence and know-how to look for help if they are worried?
I think many of these things are certainly addressed by CASA volunteers throughout the course of their case. I mean, obviously it depends on the age of the child, but from things that are addressed in reports and emails and conversations and such, a lot of these things are part of CASA, I guess you could say.
Practical strategies to help children build resilience. Select each topic for ideas on how to help children build resilience. Problem solving. Parents can help children build resilience and confront uncertainty by teaching them to solve problems independently. While the gut reaction of the parent might be to jump in and help so that the child avoids dealing with discomfort, this actually weakens resilience. Children need to experience discomfort so that they can learn to work through it and develop their own problem-solving skills. Without this skill set in place, children will experience anxiety and shut down in the face of adversity. Build a strong emotional connection. Spend one-on-one time with your child. Children develop coping skills within the context of caring relationships, so it's important to spend one-on-one time with them. This means you need to put down the smartphone and focus on your child. When children know they have the unconditional support of a parent, family member, or even a teacher, they feel empowered to seek guidance and make attempts to work through difficult situations. Positive connections allow adults to model coping and problem-solving skills to children. Promote healthy risk-taking. In a world where playgrounds are made safe with bouncy floor materials and helicopter parenting, it's important to encourage children to take healthy risks. What's a healthy risk? Something that pushes a child to go outside of their comfort zone, but results in very little harm if they are unsuccessful. Examples include trying a new sport, participating in the school play, or striking up a conversation with a shy peer. When children avoid risk, they internalise the message that they aren't strong enough to handle challenges. When children embrace risks, they learn to push themselves. Label emotions. When stress kicks in, emotions run hot. Teach your child that all feelings are important and that labelling their feelings can help them make sense of what they're experiencing. Tell them it's okay to feel anxious, sad, jealous, etc., and reassure them that bad feelings usually pass. Teach problem-solving skills. The goal is not to promote rugged self-reliance. We all need help sometimes, and it's important for children to know they have help. By brainstorming solutions with children, parents engage in the process of solving problems. Encourage children to come up with a list of ideas and weigh the pros and cons of each one. Resist the urge to fix it and ask questions instead. When children come to parents to solve their problems, the natural response is to lecture or explain. A better strategy is to ask questions. By bouncing the problem back to the child with questions, the parent helps the child think through the issue and come up with solutions. Demonstrate coping skills. Deep breathing exercises can help a child relax and calm themselves when they experience stress or frustration. This enables them to remain calm and process the situation clearly. Embrace mistakes, theirs and yours. Failure avoiders lack resilience. In fact, failure avoiders tend to be highly anxious children. When parents focus on end result, children get caught up in the pass-fail cycle. They either succeed or they don't. This causes risk avoidance. Embracing mistakes, your own included, helps promote a growth mindset and gives children the message that mistakes help them learn. It can be helpful to talk about a mistake you made and how you recovered from it. Promote the bright side. Every experience has one. Optimism and resiliency go hand in hand. Some children may appear more naturally optimistic than others, but optimism can be nurtured. If you have a mini pessimist on your hands, acknowledge the feelings that lead to the pessimistic thinking and teach your child to reframe his thoughts to find the positive. Go outside. Exercise helps strengthen the brain and make it more resilient to stress and adversity. While team sports are the most popular method of consistent exercise for children, all children really need is time spent outdoors, engaging in a physical activity. If team sports don't appeal to your child, encourage them or introduce them to bicycling, playing tag, or even just swinging at the playground. These are all great ways for children to engage in free play that also builds resilience. Model resiliency. The best way to teach resilience is to model it. We all encounter stressful situations. Use coping and calming strategies. Deep breathing can be an effective way to work through stress. Always label your emotions and talk through your problem-solving process.
I think these are all very, very good examples.
If we support children, young people and families to build resilience, it could help reduce the impact of ACEs and reduce levels of low mental well-being by 27%, not feeling optimistic about their future by 43%, not feeling useful by 48%, not feeling relaxed by 38%, not dealing with problems well by 31%, not thinking clearly by 34%, not feeling close to other people by 25%, not being able to make their mind up about things by 26%. How do you build resilience? Select your answer below and then check your response. A. Supportive relationships with trusted adults who are resilient themselves. B. Supporting children to engage in physical exercise, healthy diet, hobbies and interests. C. Supporting children to take managed risks and develop problem-solving skills. Or D. All of the above.
Off with this. Okay. There we go. There we go. There we go. So that anyway, that's the end of that training. I think that that last section, in terms of strategies and ways of supporting youth, gives some really concrete examples That sometimes I think concrete examples are kind of lacking. So I think that those are all very helpful. Does anybody have, I like to try to keep it to about an hour and a half. I don't want to keep anybody too much longer. I know we get zoomed out if we go too long. Does anybody have any final thoughts, questions, comments that they want to share? I know a lot of this is very applicable to a lot of the youth that CASAS work with, including current CASAS who are here today. So does anybody have anything that they would like to share? Any final closing thoughts?
I think it's you commented on the foster families, the current caregivers. There's I see two forms. I see caregivers who are there to take the child out of the adverse situation that caused the disruption to begin with, and then this therapeutic foster care, which takes it a step beyond that and actually addresses the challenges that the kids are dealing with. And I'm seeing that. I'm seeing more of kids who are in placement, and they're basically in placement, and I'm looking at it and saying this kid actually needs those issues to be addressed, not just not just removed from the situation, but there's actual repair work to be done. I think we as CASAS can do some of that by advocating with the
Oh, you went on mute, Patricia.
sorry, I hit that button by accident. I think we as CASAS can work with caregivers to identify issues where they can focus on working with the kids to help them deal with, not just remove them from the situation, but actually deal with the situation, whether it's in therapy or whether it's how they address everyday situations. I'm thinking in particular, not to be specific, but on my current case, I have caregivers who have identified an issue, and their their gut reaction is to block, prevent, isolate, because it's a challenge for the kids to actually address the issue or figure out how to deal with the issue. And we're working as a team. We're working with them to try and help them understand that protecting the kid or doing the best for the kid may not be isolating them completely from addressing the issue. Sometimes that issue actually does need to be addressed.
Yeah, absolutely. Sometimes tough things are an important experience. So I think that's very important. Thank you. Thank you very much. Absolutely. Does anybody else have any final thoughts? All right, well, I think we are at pretty much exactly an hour and a half. I really thank everybody for your time today. I hope it was beneficial. If you want links to the training or to the video, just send me a quick email and I will send them if they might be beneficial for someone you know or you want to share them with anybody. Send me an email and we'll certainly get those over to you. Again, Dr. Nadine Burke-Harris's book is called The Deepest Well, and I believe that we have copies here at the CASA office if anybody is wanting to read that. Let me know and I can make sure a copy is available for you. And again, thank you very much for your time and have a wonderful rest of your week. I'll talk to you soon, I'm sure. Bye, everybody.